Welcome to our webinar today. My name is Tracy Cooks with Sachs Healthcare Communications, and I'll be your webinar producer for today's event. I would like to introduce our moderator for today's session, Kathleen Volman. Kathleen is a critical care clinical nurse specialist, educator, and consultant. She has published and lectured nationally and internationally on a variety of pulmonary critical care, prevention of care, acquired injuries, work culture, and sepsis recognition and management. Kathleen is a subject matter expert for the prevention of CAUTI, CLABSI, and HAPI, as well as the sepsis recognition management and the culture of safety for HRET in the Michigan Hospital Association. Ms. Woolman was appointed to serve as an honorary ambassador, World Federation Critical Care Nurses. Kathleen, welcome.
Welcome, everyone, and thank you so much, Tracy, for the kind introduction. The title of today's webinar is Resuscitation During a Pandemic. Speaking today on this very timely topic is a colleague and friend of mine, Nicole Kopchak. Nicole has practiced as a critical care nurse for over 20 years. About 15 years ago, she began working at Harborview Medical Center, a change that spurred an interest in resuscitation. Shortly thereafter, Nicole was part of a multidisciplinary team that was one of the first in the United States to implement therapeutic hypothermia after cardiac arrest. As part of this effort, Nicole was responsible for protocol development and has published numerous papers on this topic. In 2013, Nicole founded Nicole Kopchak Consulting and Education. Nicole discloses the following relationships: Speaker Bureau for Stryker and La Jolla Pharmaceutical, and a consultant for Baxter Healthcare. This educational activity is approved for 1 contact hour. A link to obtain CE credits will be available at the conclusion of the webinar. Listed are the accreditation statements. Support for this educational activity is provided by Stryker. Now I'd like to turn the presentation over to Nicole.
Well, hello, everybody. Good afternoon, morning, evening, whatever time it is that you are listening to this. I'm really excited to chat about this topic, only because I think some guidance is needed around resuscitation during a pandemic. And I have a lot of experience, not with the pandemic, obviously, but in just kind of working through logistical considerations, especially for resuscitation in difficult situations. And as many of you know, if you followed these series, I ran a Code Blue committee for a lot of years and implemented mock codes. And then I also was a clinical nurse specialist through H1N1. And I will tell you that experience was invaluable in kind of preparing for pandemic type situations. And I'm going to really share a lot of the things that we had implemented and experiences we had that would be absolutely applicable to resuscitation today. So learning objectives, again, we're going to discuss logistical considerations of a team response for resuscitation. I'm going to chat about safety during intubation. As you know, intubation is an aerosol generating procedure, and so really your safety is the utmost importance. So we're going to chat about that. And then I'm going to talk about modifications to consider to really, during the resuscitation response in general, to minimize viral exposure. So a couple things about COVID-19, which I think is just absolutely fascinating, is right now, and I will say right now because I think the data are changing pretty much daily, they're estimating about 3 to 6% of patients who have COVID-19 require critical care. And I will say, I think that might be an overestimate because we don't know the true denominator of COVID-19, to be completely honest. But as you all know who have seen these patients in the emergency department, critical care, maybe even in the EMS setting or in progressive care type settings, these patients who deteriorate experience significant hypoxic failure, which can lead to an ARDS type picture. These patients get bilateral pulmonary infiltrates with ground glass changes on their CT scans. And so they do, I'm not going to get deep into the discussion, but there are currently a thought of there being two different phenotypes of COVID-19, but what we know in critical care is these patients, again, get hypoxic failure, they can deteriorate, but the secondary thing we're seeing is myocardial injuries. These patients are developing like a myocarditis. They're going into heart failure. They're seeing EFs around the 10% range. They're also developing ventricular arrhythmias and going into shock. Now, to kind of add to the complexity of all of this, medications that are currently being studied, like for example, hydroxychloroquine, prolongs the QT interval, which can lead to ventricular arrhythmias. So these patients are super complex, and we really need to be prepared for any deterioration and what our response is going to be to that deterioration. So one of the things I want to make super clear, I want to make ultra clear, is in a pandemic, there is no such thing as an emergency. And so what do I mean by that? Well, what I mean is you need to pause and take the time to protect yourself first. And what I mean by that is put on your PPE before running into a room. I cannot stress this enough. If you have a patient who has COVID-19, you first need to don your PPE. And, and it was interesting. So back in 2009, when we had H1N1, which again, it was not a pandemic, it was not as virulent as COVID-19, but we did multiple mock codes during that time because we had concerns about staff not protecting themselves. And I cannot tell you how many times we did mock codes, and we would it would be presumed H1N1, we would have all the PPE outside the room. I cannot tell you how many staff heard code blue overhead and went running into these rooms without protecting themselves. So again, and I will keep stressing this, you need to protect yourself first. Your safety is paramount. If our healthcare providers are not healthy, our general public will not be healthy. The next thing I want to just briefly mention is the whole idea, around advanced directives. Like, what do you do with these patients? Do you make them all DNRs? Do you, do you have them, do you address advanced directives? What do you do with these patients? And one of the things I'm going to say is I'm not a believer in making all of these patients DNRs. That's my opinion. But I'll kind of extrapolate on that in just a little bit. But one of the things that should be commonplace is addressing the patient's wishes on admission. If you have a patient who is from the beginning saying, I do not want to be resuscitated, I do not want chest compressions, it's easier to address that in the beginning when they present versus when you're in the situation. And I mean, that could be said for any patient regardless of their diagnoses. The other thing I would say that would be really helpful is to understand what your institution's approach is going to be if you do indeed see a massive surge. Now, I will say, this is being recorded in April, and luckily in a lot of areas of the country, we're starting to see kind of a downward tick in ICU admissions and intubations and things like that. However, I think this is something to really talk about because there is a lot of discussion about possibly seeing another surge in the fall. So we're all probably going to get a break in the summer and in July. And these are the types of things that should be discussed, especially once we get kind of past the surge that we're seeing right now with the pandemic, is what is your institution's approach going to be to resuscitation if we do see another surge? And then in general, when you're just kind of thinking through, okay, we've got a patient who's coding, how am I going to approach this? One of the first things you should be asking yourself is there anything that is immediately reversible? And if not, then comes the whole question of futility and what is going to be the outcome in this patient population. So let's just kind of revisit those immediately reversible things. And we've all learned these. It's your 5 H's and 5 T's. And in COVID-19 specifically, I think there are about 5 things that we can immediately go to, right? So is this patient overtly hypoxic, and can we reverse that? Is this patient overtly acidotic, and can that be reversed? Does the patient have a PE? Because we're finding, or maybe even an MI, we are finding these patients are hypercoagulable and blood clots are a major issue. And then finally, is there a tension pneumothorax? Is the patient on a lot of PEEP? Can we put in a chest tube and reverse the cause of the cardiac arrest? So in general, I think that's one of the first questions you should be asking yourself in resuscitation of any of these patients. Is there something that we can immediately reverse to improve the outcomes if these patients do have cardiac arrests? Just to kind of expand a little bit more, if you've got a patient who's intubated, there's an acronym called DOPE, and these are things that are immediately that you should it's kind of a checklist that you should go through if your patient deteriorates or does have a cardiac arrest. So first of all, if they have an advanced airway, has that endotracheal tube been displaced? Is the tube in the right main stem? The O in DOPE is obstruction. Is the ET tube obstructed? Is there a mucus plug? Is there kinking in the tube or in the ventilator tubing? The P in DOPE is pneumothorax. You can quickly do a bedside ultrasound, or maybe even get a gas to look for overt hypoxia, an ultrasound to assess for pneumothorax. I say get a chest X-ray, but the reality is, if you've got somebody who's coding, that's not very helpful. Now, if you've got somebody who isn't coding, who's maybe kind of deteriorating from an oxygen standpoint, then maybe it would be appropriate to get an X-ray. The E in DOPE is equipment failure. So, very quickly look at your ventilator, assess that it's working. If it's not working, unfortunately, you may have to give the patient assisted ventilations. But again, this acronym DOPE just really helps you think through common causes of post-intubation hypoxia or deterioration. Now, the AHA just published guidelines specifically for COVID-19 patients. And I just want to give the AHA kind of a hat tip to say thank you for rapidly getting these guidelines out. It's really tough. None of us who are practicing right now have ever been through a pandemic. So, critics might say, well, where is the evidence, in these guidelines? And here's the reality is we've not been through a pandemic. And so a lot of the guidelines that I'm going to introduce today from the American Heart Association and then the Department of Defense a lot of it's based on expert opinion, because that's what we have right now in a pandemic. But let me just kind of walk through some highlights of where things might be a little different. So I want to be clear to say in that there are no changes in the fact that chest compressions, high performance CPR is absolutely paramount. You need to defibrillate a shockable rhythm as quickly as possible. You need to establish an airway. Medication, so you can still, consider giving your epinephrine 1 milligram every 3 to 5 minutes. And if you've got a shockable rhythm that's not responding to defibrillation, you can try amiodarone and lidocaine. And then again, just assessing those reversible causes. But where might the guidelines be a little bit different? And I love this, but it's really focusing on you, making sure that you are protected going into these patients' rooms. So you can kind of see up at the top, I've highlighted don your PPE, consider resuscitation appropriateness in these patients. Number one, it's your safety. You need to protect yourself. Other things, so prioritize intubation and keep on the chest. Now, they made a point to say pause chest compressions for intubations, but I would say be really careful around that. One of the things we know for sure is that when we have pauses in chest compressions, it leads to worse outcomes. So you've got to be able, and I'm going to talk about just some tips and things to consider for airway placement if you're placing an airway as part of your resuscitation. But I'll come back to that. And then connect the ventilator with a filter when possible. And I'll also kind of show you some examples of that. And then, in general, try to keep your circuit as closed and merely minimize disconnection as much as possible. And I'll also give some tips around that. And then finally, it's just the basics, staying on the chest and minimizing interruptions and chest compressions. So the Department of Defense back on March 23rd had published best practice guidelines. And again, people might be critical and say, oh, where's the evidence? But we've not been through a pandemic. So what they did was kind of went through the literature and to their best, they created what they call best practice guidelines, where they kind of set minimum standards, better standards, and then best practice. So minimum practice, better practice, and best practice. And so a couple things I want to point out is I kind of love around advanced practice, advanced directives. They pointed out best practice as developing a script for the clinician that incorporates unique and ethical considerations. And I think in a lot of hospitals that would be really helpful. The other thing that was discussed is maybe creating a specific COVID-19 code blue team, which I think is super reasonable. Having, using PAPRs and having a PPE checklist, and I'll kind of go through some ideas for that as well. Communication can be really challenging, especially if you have to wear a PAPR or an N95 mask, while you're in these rooms, because you really want to minimize opening the door and minimize the amount of people that are in these rooms. So, using things like the whiteboard, or maybe even a lot of patient rooms have glass windows, so writing on the windows with a marker that can easily be wiped off. The other thing is using maybe like a speakerphone in the room, or Vocera, or maybe even a cell phone to communicate with people outside the room if you've got things that need to be brought in. Other things to consider would be so CPR, minimum practice, rotating 2 people who don't leave the room, whereas best practice would be using a mechanical CPR device. IV access, better practice inserting an intraosseous line. Now, usually we use the humerus as an access site, so in clinical practice, just consider that. Whereas best practice might be establishing a central line before the patient has an arrest, especially if they're really sick. Around ACLS equipment, having dedicated crash carts for COVID-19 rooms or units. And then best practice, having ultrasound, an ECG machine, maybe portable x-ray that's all dedicated to a COVID-19 ward. And then airway, you could see kind of minimum practice being like a non-rebreather mask with a patient mask over it, whereas best practice would be, early intubation before the arrest even occurs. So I'm going to point out some of the DoD best practice guidelines as we go through the webinar. So again, I've said this a million times already, but, protect yourself. Everything you do in resuscitation, or I should say just about everything, is an aerosol generating procedure, or an AGP. So intubation, positive pressure ventilation, doing chest compressions. And in these cases, using a PAPR or a CAPR would be ideal, but an N95 should be used. So one of the ideas that we had and that we implemented during H1N1 was having like kind of a grab and go bag. So having a grab and go bag of PPE on the crash cart, so you're not fishing around, looking for extra PPE. So we would had a grab and go bag of 4 N95 masks. We put gowns and then 4 eye shields, just to make sure that the people going in the room have easy access to PPE. So another thing to consider, and I cannot stress the importance of this, is minimizing who goes in that room. Now, how many of you feel like when you just now, minus COVID-19, how many of you feel like when you have a cardiac arrest or a code blue that's called overhead, this many people show up to the room. I know this is kind of an exaggeration here, but I mean, a lot of us feel like, often we have way more people in the rooms than what are needed. Maybe you work in a teaching facility and it's to facilitate learning, but these are special considerations and these are special times where really you need to minimize the number of people that go into these rooms to minimize exposure. And I'm going to give you a lot of ideas around that. So who should respond? And I think goals, so just a basic goal would be to minimize exposure while maintaining a high level of care. You want the minimal number of people in the room. Another just overarching idea is to position the crash cart outside the room with a person outside the door who's dressed in PPE, who can hand off supplies to people in the room, but keeping the door closed as much as possible. Unless you've got a completely negative, kind of a negative air pressure unit, and if that's the case, then you can alter based on that. But the Department of Defense actually had made a statement if a specialized kit is not available, consider placing supplies through a crack in the door onto a bedside table that's in the room, but avoid physically handing it off to a person. And I think that's a really decent approach to just kind of minimizing contamination in general. So another grab and go kit that you can consider making would be kind of emergency meds and or maybe even one with airway supplies. So a basic grab and go kit could have, like, for example, defib pads, capno tubing, a couple amps of epinephrine, maybe some amiodarone, and then handing off the CPR backboard as well. So who should respond to the cardiac arrest? And that's, a lot of this is going to depend on what your resources are at your hospital. It's going to depend on personnel that you have available. It will may also depend on if it's day shift versus night shift. But so just some general basic considerations is the idea of having a dedicated response team, be it in the emergency department or maybe in the ICU or acute care areas. This is not the time where best practice would be calling a code overhead and having just random people show up. I really do strongly believe that there should be a dedicated response to resuscitations. And then when you activate a team, you have to decide, is this going to be unit based? So for example, in my emergency department, am I going to have like a smaller team that responds to a cardiac arrest versus hospital based? Would I have maybe people coming from the ICU and progressive care to respond, to a cardiac arrest? And this really, truly, I can't say enough, needs to be customized based on the location in the hospital and what resources you have. But I wanted to kind of set up what some basic schematics would look like in logistics of a resuscitation. So this is the patient's bed. Head would be up here, feet down here, and then the door. So just some basic schematics to think about and again, the goal being to minimize the number of people that go in the room, is having two people that would provide chest compressions. Have one person who administers medications and runs the defibrillator. Having 1 to 2 people on airways. So, at minimum, having a respiratory therapist there, but maybe having a second person who places an advanced airway. So if the patient already has an advanced airway placed, then you can already maybe minimize and have one less person in the room by getting, kind of taking away that person who places advanced airways, and then having your leader at the foot of the bed. So in a schematic like this, you could get away with 6 people in the room, positioning someone outside the door as someone who does recording and maybe hands off supplies with the crash cart. So this would be kind of like most people you could get away with. Now, I'm going to actually give you some ideas of how to really take that number down even more. So if you have a virtual ICU or an EICU where you have a camera into the room, one of the questions I would ask is, could you have your leader of the code maybe lead the code and give direction from their EICU or from a virtual capacity. And so in that case, you would still, if you're doing manual chest compressions, you would have 2 compressors, someone who's giving meds, running the defibrillator, someone on airway, and then have your crash cart and recorder outside the room, but have that that leader of the resuscitation outside the room, and maybe even the recorder could come from the EICU. So Fiona Winterbottom is from, she's amazing, clinical nurse specialist from Ochsner in New Orleans, and they've got a very strong EICU, and I've worked at hospitals with strong EICUs. So this could be another approach to logistics in response to cardiac arrest for COVID-19. Now, I'm going to take it even a step further. One of the other things you could do is consider using mechanical CPR. So if you've got a mechanical CPR device, now is the time to really consider using them. So in this type of a schematic, you'd have a person who's giving meds. Now this would be once the device is placed, because you need a couple people to place the device. But once the mechanical CPR device is placed, you'd have a person giving meds, running the defibrillator, one person kind of overseeing airway, and then have a recorder outside with the crash cart. And then if you had a virtual ICU, you could have the leader outside of the room. So really, if you had a virtual EICU, you could run a resuscitation with mechanical CPR with only 2 people in the room. But maybe if you don't have EICU or virtual ICU, you could bring that leader into the room and and run a code with 3 people. So I'm just giving all kinds of options to think about. And I think after the dust settles with this, if you don't have an approach, you should definitely make an approach. And just in case we do see another surge in the fall. So in general, chest compressions are considered an aerosol generating procedure, and the Department of Defense established minimal practice, better practice, and best practice. So minimal, again, would be having 2 people in the room who don't leave the room, who switch off doing CPR. Better would be to rotate 2 people who don't leave the room, and then they would accomplish multiple tasks based on pre-established priorities. So kind of, when you aren't doing CPR, maybe you would be the person pushing meds. Whereas best practice would be using an automatic chest compression device. So, again, I just think you've just got to go back after the dust settles and kind of really look at what you've got in your hospital, what some of your limitations would be, and then coming up with a plan for next time. Now, one of the reports we're hearing is that a lot of people, not a lot of patients, but in patients who do have a cardiac arrest, that they're going into VFib. And we do know that there's cardiac dysfunction that's associated with COVID-19. So what do you do if you've got somebody who's in a refractory VFib and you just can't get them out of it? Well, first of all, you would do everything you would for any other patient who's having a cardiac arrest, in that you want to minimize, well, let me back up. You want to maximize chest compressions, minimize interruptions. And then one of the things I just want you to think about is if you've got somebody who's in VFib, is think about changing your pad placement. So you should be escalating your energy and getting to the maximum amount of energy that you can with your defibrillators, but think about changing the position of the pads. So if you're going anterolateral, think about changing the pads and going anterior posterior and vice versa, but changing the vector or the direction through which the energy is being delivered. And just for VFib in general, the other thing that I get held up on a lot is big, long pre-shot pauses. So if you can, charge your defibrillator at a minute 45, have your defibrillator ready to go. So when you take that break at 2 minutes, you can readily assess shockable rhythm, yes or no, and immediately defibrillate and then get back on the chest to minimize pauses. So let's chat about this whole really comfortable idea of prone CPR, right? Because one of the things that we're doing for patients who have respiratory issues and major hypoxic issues is we're placing them in the prone position. And so we're literally putting them on their stomach, whether they're intubated or not. This has been a really successful approach to improve oxygenation. So what do you do if the patient is in the prone position and has a cardiac arrest? Well, one of the things you can do is start manual chest compressions on the back. So you would place your hands at about the T7 to T10 place on the spine. But one of the really important things is you have to have some sort of a counter sternal pressure to kind of get the most bang for your buck out of doing compressions from the back. You can place pads anterior posterior. So I kind of made a little symbol here of where you would place a defib pad, and then the other pad would be placed on the left front portion of the patient's chest. And then I just tried to highlight the T7 to T10 hand placement for chest compressions. And you can kind of see this is what prone positioning, anterior, posterior pad placement would look like. Now, I want to be super clear to say that if the patient is in the prone position, you should not place a mechanical CPR device. You really, if you're going to use mechanical CPR, it should only be with a patient in the supine position. There are absolutely no data on placing a mechanical CPR device on a patient in the prone position. So if they have an advanced airway, you can start manual compressions on the back with the end goal being to get them in the supine position. And I'll have to say, so the American Heart Association, in all of their guidelines that I can remember, have just said, that if the patient cannot be placed in the supine position, it's reasonable to start CPR in the prone position, particularly in hospital patients who have an advanced airway in place. So what are the studies supporting prone CPR? I'm going to be super honest. It's really limited. It's mostly case reports. The case reports mostly come from the OR. And if you think about it, a lot of patients who have spinal surgery have to be placed in the prone position during spinal surgery. And that patient population can have bradycardic and PEA episodes from a lot of parasympathetic innervation. But the only study I could find that evaluated prone CPR was a two-part study that was done in 11 patients. So again, the limitations are massive, in the research, but it was a two-part study that was done on 11 ICU patients who had passed away. So the first part of this was a circulation test. And what they did was they compared standard CPR and they evaluated the blood pressure that was generated from standard CPR. And then they turned the patient prone and reevaluated the pressure that was generated using the same force. And they used a rate of about 60. Now you might say, well, why did they use a rate of about 60? Well, if you kind of look at when this study was done, it was done back in 2006 when there wasn't as big of a focus on hitting a rate of at least 100 in chest compressions. And so just to kind of be super clear, so these were patients who had passed away. This was done out of China. And what they did was standard CPR, measured the pressure generated, and then turned the person prone. And what they found, you can see supine CPR, the pressures that were generated versus prone CPR, much, much, much higher pressures were generated. And it was a statistically significant difference of being able to generate higher pressures in the prone position versus in the supine position. And so really these results do support the concept of the thoracic pump model in response to resuscitation. So again, super, super limited data. Now, the second part of the test was they took healthy volunteers. They had 10 healthy volunteers and put a nose clip on these people and just looked at basically looked at the volumes they were able to exhale, and in the prone position they were able to exhale decent volumes. So I don't know, this is all so limited, but there is a tiny bit of data with case series. So what if the patient arrests in the prone position without an advanced airway? And in that case, because I think one of the biggest concerns is if you're in the prone position and we flip you to supine, the big concern is losing the airway. But if they don't have an advanced airway, maybe best practice around this would be to attempt to place the patient in the supine position and get manual chest compression started as quickly as possible, and then use a mechanical CPR device if you have one. So obviously, as far as chest compressions, if we're considering prone airway, chest compressions would be easiest in the non-intubated, flip them to their back and do supine chest compressions. So, really, really tough. We are literally practicing in times where we have very, very, very limited data to support, what to do in these situations. So again, a big, hats off to AHA and the Department of Defense for trying to give us some guidance based on what information exists out there. So what if the response requires intubation? So what if you have a patient who has a cardiac arrest and they need to be intubated? Well, first of all, the most experienced person really should be doing this. And ideally, you would be intubating in a negative pressure room, but that's not always the case, in resuscitation. But just about every organization has said, if intubation is an aerosol generating procedure, you should be wearing at a minimum a PAPR or N95 mask. And then just a reminder that CPR, chest compressions, are also considered aerosol generating procedures. And this is where kind of having your grab and go airway kits would be really helpful, or maybe having an intubation tray that you would bring in the room so that you're minimizing exposure of people in and out of these rooms. But one of the most fascinating things I have found during this whole entire pandemic is the innovation that is coming. And I would dare to say healthcare will never be the same after this pandemic. But you can see this is again from Fiona Winterbottom out of Ochsner, and they asked their 3D department to develop, basically it's like a plexiglass box that they can put, so you can see there, we can't really see it really well in the bottom position, but there's a cutout for the patient's neck. But basically you would position, this is a physician out of Taiwan who had also created a box, but you would put this box over the patient's head, and then it has hand cutouts where you could use video guided laryngoscopy to place an advanced airway. So really novel ideas for what we're facing in this pandemic. Now, the other thing that we're starting to see over and over and over again is the use of plastics. So you can, and I have a feeling once the dust settles from this pandemic, the companies will be making maybe a better designed plastic shields that go over the patient's head with, slits for your hand to really minimize any aerosol spray that would happen during intubation. So, stay tuned, because I really don't think, any of this is going to be the same after the dust settles. Now, another thing to consider in a non-intubated patient is that maybe you can use, and this was published in the American Heart Association guidelines, is use a non-rebreather mask, face mask with a mask over it to minimize aerosol generation and spray in the room. So if the patient arrests without an advanced airway, some other things to consider is that you can use a bag valve mask with like a HEPA filter, or some sort of like an HME filter that kind of filters viruses. So we're really trying to minimize any aerosol generation. So keeping a super tight seal on the patient's face with a HEPA filter. And then, you can also consider a subglottic airway. I mean, I'll just be super clear to say, if you're going to place an airway, an endotracheal tube is really going to minimize any aerosolization, but you can also consider a subglottic airway with maybe even a self-inflating, like an anesthesia bag in certain instances. Now, intubation, again, just a reminder, the most experienced person really should be doing this with attempts to get the airway placed in first pass. And that's where video guided laryngoscopy can be absolutely essential and minimize exposure of whoever's placing the airway. So you can kind of see this is an example of video laryngoscopy where you can really clearly see vocal cords and to place the advanced airway on the first time. And then I just want to make another just a reminder, ideally you really want to minimize interruptions and chest compressions while you're placing your advanced airway. Okay, so now what do you do if the patient has an advanced airway? So let's say you've got a patient who's already intubated and they've got an advanced airway. Well, a couple things to think about is maybe just keep the patient on the ventilator. And I would actually argue this just in general, minus COVID-19. But the American Heart Association did include in their guidelines that you can maybe consider keeping the patient on the ventilator, adjust the rate down to 10, unless any airway obstruction is suspected, and that would be the reason for the cause, but adjust the rate to 10 and then use a lower tidal volume of about 6 mils per kilogram of predicted body weight, and then just flip your FiO2 up to 100%. And then for neonates, in the AHA guidance, they suggested 4 to 6 mils per kilo at maybe a rate of 30. But this is an example. So Karen Lorche, who is a respiratory therapist who I do a lot of work with, gave me this picture, but this is kind of just showing a schematic of an endotracheal tube and then using an inline filter on the expiratory limb to minimize aerosolization. And then the other thing you can see here is an inline suction catheter, which would be absolutely paramount to use, if you've got somebody who's intubated and going to stay on a ventilator. So HEPA filters, again, can be used, once the patient's intubated, we want to do everything possible to keep that circuit closed. So how do you attain that? Well, you're going to use a cuffed endotracheal tube, inline suction catheters, like I had previously mentioned, and then, a HEPA filter. So this is an example of a HEPA filter on the expiratory limb in line with a ventilator. And then this is Karen's picture, just as a reminder, of using it during resuscitation with the patient kept to the mechanical ventilator. All right, so some other things to consider, so I'm going to wrap up here, and so some other things to consider is if the patient has an arterial line, use the diastolic pressure as a marker of CPR quality. Ideally, you want, now I'm just going to state a reminder of you need to make sure that that transducer is at the phlebostatic axis, but your goal should be to get the diastolic pressure at least 20 or higher in most situations. Capnography should be used. It absolutely should be used during resuscitation. But one of the things you're going to have to remember is that patients with COVID-19 have big VQ mismatch, or maybe the cardiac arrest is caused from a big pulmonary embolism. And in those types of cases, capnography is not overly helpful to be used as an indicator or marker of CPR quality. So you just have to understand that there are going to be some limitations around capnography use during resuscitation. And then in general, just having a discussion with the team, what are the endpoints of resuscitation for these patients? How long, how much, effort are we going to make in patients who have COVID-19? And then if you do get return of spontaneous circulation, just remember all of those things that you normally would do for post-arrest care in temperature management, making sure their hemodynamics are stable, turning down the FiO2 and not blasting them as long as their SpO2 is at a level that you're comfortable with. Now, the final thing I'm going to just chat about is the final two things would be debriefing. I can't say how important debriefing is, especially at a time like this. A lot of us who work in the emergency department and in critical care are seeing death at unprecedented rates. Now, I'm not saying COVID-19 mortality is unprecedented, but we work in specialized areas who take care of the sickest of the sick. And I truly believe we all need to talk about this. You are practicing through really stressful times. And debriefing is now more than any time is going to be really, really important, and just make sure, if you're doing debriefing, that you have a safe environment, that you're not placing blame on anyone. I think everyone right now is doing the best they can, but maybe just think about thanking everyone for their efforts and asking 3 questions. What went well? In general, in debriefing, when you ask providers what went well, a lot of people will stand silent because they're beating themselves up. And I just think no, there's a lot of things that went well, and just reminding each other what those things are. What would you do different next time is a really good question to ask. With, again, not in a blameful way, but like, let's say if this happens again this shift or maybe next shift, what would we do different? And then, were there any safety or equipment concerns? And at this time, that question is so important, and making sure that any safety or equipment concerns are appropriately communicated to people who are in positions to make change and keep you safe. Okay, finally, when the dust settles, I think something that really, really should be considered are doing mock codes, especially when the dust settles. Just in case we do see a resurgence of this in the fall. But again, I did so many mock codes during H1N1, and we found just like we found the things I talked about earlier. Just staff were not always protecting themselves, and we had to make some modifications to crash carts, and so I really, really do think you should consider doing mock codes, maybe in June or July, when you're not seeing as many of these patients, you're really walking through what your approach will be next time. So I just want to thank you for joining me on this webinar. I really hope this gave you some ideas of things to consider for the future. And, again, remembering your safety is the #1 priority in this. Immediately consider reversible causes in patients who have cardiac arrest with COVID-19. Have a plan for your response. Really focus on minimizing the people that are going in and out of the rooms. Consider mechanical CPR devices, especially if you have them in your facility, and then using HEPA filters and keeping your line closed and not opening your ventilator lines whenever possible. And then bottom line, just please, please, please take care of yourself. So with that, I'm going to hand it back over to Kathleen Volman. I listed the references here that I used for this webinar, and then the two references from AHA and the Department of Defense being the most recent that have been published. So, all right, so Kathleen, I'm going to hand it back over to you so you can give some instructions for all the listeners.
Thanks, Nicole. That was a really informative session and a lot of practical information that I think we can move into our practice. But before we begin the QA session, I have a few reminders for the audience. This activity has been approved, this program, for one contact hour. Please go to saxtesting.com/SL, and you're going to need to register on the test site and complete the evaluation form. Upon successful submission, RTs and nurses will be able to print the certificate of completion. And so I'd like to start the Q&A. We have some questions for you, Nicole. The first question we have is, what are your thoughts on making every intubated COVID-19 patient a DNR? You sort of shared a little bit about that with us, but I'd like you to get a little bit more in depth on your thinking.
Yeah, honestly, I think it's a massive slippery slope. I personally am not a big believer in making everyone a DNAR. I mean, every facility is going to have to. You do the best you can, #1. But so I guess I would push back on that and say, so what if we have let's say let's use my age, a 48-year-old who's got a mucus plug, who obstructs their airway and has an arrest from it. It's completely reversible. And I think you've got to be really careful in making blanket protocols like that. And just I don't know. I really struggle with this from an ethical perspective, as I'm sure many listeners do. I don't know. What are your thoughts, Kathleen?
Well, I think what you brought up in terms of addressing patients' wishes on admission is a really important component. I think hospitals are addressing, um, not to me a blanket DNR on COVID-19 patients, every intubated one, but they're looking at based on the number of comorbidities and the presence of, you know, terminal illnesses, because that does exist, that we still intubate and manage those patients, that they're looking at policies and procedures to address that. But I 100% agree with you, a blanket DNR for intubated COVID-19 patients is not appropriate.
Yeah, it's a tough one, right? It's a tough one.
Right.
Yeah.
So one of the things, another question, you talked about an intubation box or an airway grab and go or something. How do you get one of those?
Yeah, well, I'll be honest, we had to make them up ourselves, right? So,
Okay.
yeah,
That's
you know,
creative.
yeah, no, totally. But we ended up during H1N1 having just kind of a little bag, or I think actually I got some tackle boxes and put some. I worked with respiratory therapy and our patient safety department with medical stores and put together little boxes that had like the immediate supplies you would need for airway rescue. Because the one thing you don't want is in, out, in, out, in, out. The other thing you can do is use like a plastic bag, and then that way it's disposable and you can just get rid of everything.
Right,
Because
without
that's
having to worry about cleaning.
yes, exactly. So, and that's one of the struggles I think a lot of facilities are faced with now is like, well, what do you do with a crash cart? Well, I think the most logical thing is don't take the crash cart in the room, and just maybe have these grab and go kits that you can kind of place in the room, and with just the whole thought that everything in it is disposable.
So would you think about doing something like that for the medications as well and defib pad?
Absolutely. Yes. Yeah. And the grab and go kit, like I was talking about, we put, I think it was 3 EPIs and amiodarone in it with capno tubing, defib pads. And I think those were the main things that we had put in there. Yeah. And then just with the understanding that everything gets tossed. So you're not bringing dirty supplies out of the patient's room.
So it almost sounds like there'd be three. You'd have your PPE
Hmm.
extra, grab and
Yep.
go. You'd have your airway, grab and go, and then you'd sort of have your CPR grab and go that has your
Yeah.
meds and defib and that. That makes a
Yeah,
lot of
if you're
sense.
yeah, I mean, truly, if you're trying to minimize supplies going in and out of the room and contamination, that was our approach to it back in H1N1. So, and it worked pretty well.
So on these patients, another question would be how long would you run a code?
Yeah, I think that's a tough one. I think number one, it depends on what you think the cause of the code is, and is it reversible, and what rhythm is it? Because if it's asystole, let's be super honest. You're
Yeah, that
probably
one
not going
doesn't.
to get
Yep.
yeah, you're probably not going to get that patient back. Where if it's VFib, I mean, maybe, you can kind of keep moving forward with high performance CPR, defibrillation, and asking, asking the question, is it appropriate to take this patient to the cath lab? I mean, maybe it's not appropriate, but at least the question should be asked to give the patient the best chance. And because the one thing we're wondering is how many patients, are we, and I don't think we know the answer to this, are dying, of who have COVID-19, but like completely other causes, right? So because there are reports that PCI rates are down right now, and so are people magically having less heart attacks, or what's happening here? So yeah,
Right.
so I think a lot of it depends on the rhythm, the patient's comorbid conditions, how long they've been in that rhythm, et cetera, and is there anything immediately reversible?
Okay, that makes sense. So what if your hospital doesn't have, because I heard that you talked about best practice being a mechanical CPR device from the DoD. What if your hospital doesn't have one?
Yeah, then I think the approach that the DoD had recommended of having two people in the room that switch off doing CPR, I think that completely makes sense. What I think doesn't make sense is an open wide door with people standing all around, um, in chaos. I think really this type of resuscitation needs a very, very, very organized approach.
That makes sense. And your schematics were very helpful. What would you, and speaking, you talked about prone CPR, and you talked about a counter pressure that needs to be put in place. What types of things are you thinking that could help create that counter pressure?
Yeah, well, I think some basics of deflating the beds. If you have a patient on an air mattress, deflating the bed, using your CPR backboard. A lot of it depends on the patient's body habitus as well. I had seen some case reports where they put like a liter of IV fluid in the patient's sternum to give
Oh,
some
awesome.
counter pressure, or they put like a rolled up bath blanket to create some counter pressure. Um, but I think as a minimum, a CPR backboard with the bed deflated should be considered.
Okay, that's helpful. What are your thoughts about putting intubated COVID-19 patients on ECMO?
Yeah, I, you guys are probably sick of me hearing me say it depends, right? But it depends. It depends. It really does depend. It depends on a lot of things. It depends on what are the resources at your facility, the patient's age, the patient's comorbid conditions. I mean, if you've got somebody who is got something that's reversible who maybe just needs the support, why not? I mean, there are success cases being published right now of patients who have successfully gone on ECMO who have had COVID-19. So I think that question really needs to be answered at the institutional level, just with a clear understanding is there are a finite number of resources and
Right.
staff
Well,
and having a plan.
yeah, one of those questions I think that has to be asked, especially if you're not an ECMO center, or you are an ECMO center and receiving patients from outside, is have they prone them
Yeah.
before trying ECMO? Because that should be, or some of the other rescue therapies.
Yeah, absolutely. I think without a doubt, right? There is so in 2019 there were ARDS practice guidelines that were published, and there are things you can do before ECMO without a doubt, for sure. So making sure that you've exhausted those things and just having a planned approach to putting somebody on ECMO.
Well, Nicole, those are all the questions we have, and I want to thank you so much for this wonderful webinar that will help inform us on our practice. And I'd like to pass it back now to Tracy.
Thank you, Nicole and Kathleen, and we'd like to thank everyone for joining today's session on behalf of the Sachs Healthcare Communications and our presenters. Thank you for joining us today, and have a great rest of your day.